Adult Behavioral Health Service Landscape Training Series. My name is Meg Beyer. I have been part of this collaborative opportunity and partnership with many partners from the New York State Office of Mental Health and Office of Alcoholism and Substance Abuse Services, as well as the technical assistance training partners. I work at McSilver and am excited to be delivering a live office hours session in hopes of answering any questions that might have come up during the webinars that we recorded and launched. Just as a gentle reminder, some housekeeping. If you weren't able to listen to all of the webinars that were recorded, you can find them all on the TAC website. You can go to mctac.org, mctac.org, and you can find all of the recordings there. The purpose of this webinar today is really office hours, so we hope that you might have some questions that we could help clarify. And if you do have questions, we ask that you use the chat box function and send them to all panelists. We're going to work with all of our partners who really help to develop the presentations and some of whom are on the call today to answer them. But with that, I'm going to pass along to my colleague Boris Volgorin, who's going to walk us through some more details before we get kicked off with questions. So thanks again for joining us today.
Great. Thank you, Meg. Again, my name is Boris Volgorin. I'm also with McSilver, McTac, and we're also joined today by our partners, as Meg mentioned, both from OMH, Oasis. We also have our partners at CPI, CASA, and I believe NYS as well. And so before we get going, and again, we strongly encourage folks to submit questions. This hour has been put aside for you to really follow up on those webinars that we recorded. We already actually did get a couple of questions prior to that, both OMH got and us through different venues, so we're excited that people are listening to those pre-recorded webinars and that they find them helpful and that you find them helpful. A couple of things before we dive into the questions that have come in and hopefully will come in. One is just to look back and kind of talk about some of the big themes. There were a lot of themes and a lot of discussions during those presentations, really focusing on explaining the services and programs that are available, both from OMH and Oasis and HCBS, and then how things work together. In the first presentation, we talked about the whole transition to managed care and HCBS services. So I think there was a lot of information, but there were also some themes that I think is important to underscore and again to remind folks and see some of the reactions. One is, it's a given, but I think it's worth saying, everything you do needs to be person-centered. I think when we talk about choosing programs, when we talk about, selecting what's appropriate and what is best would fit to meet individuals' needs, I think it's extremely important that the individual you work with is part of that discussion, has a voice in that decision, and actually it's their choice at the end of the day, because I think we'll all find when that doesn't happen, there's a limited participation and involvement, and that makes sense. If the individual didn't have their voice and choice be part of that discussion. I think the other theme is, especially with webinar 4, there are options. Individuals have options, especially with the HCBS now available for some individuals who are HARP enrolled and eligible for those services. For those individuals, there's even additional option of HCBS. But even outside of that, there's still options both on OMH and Oasis side and together. I think it's important to remember that, and again, our webinar 4 try to portray some of those vignettes and examples. We also need to remember that managed care is very much part of this equation and is part of the partnership here. And one of the components, as we talk about and think through, is really thinking about how does managed care play a role, when do they get involved, and also making sure that those options and those choices are part of the managed care network. because in the managed care environment, as everybody is aware, there's contracted providers, there are networks, and those need to be part of those discussions and part of the decision-making process as well. Some of the additional things just to mention, so folks are aware, we are in the process, together with all of our partners, in developing a tool that we hope would be very helpful in kind of summarizing or helping individuals navigate really through these presentations. So this way, 3 months from now, if somebody says, I want to go to PROS, can you tell me a little bit about it? You don't have to kind of remember which presentation it was in and, what slide deck and what slide and look through all of that to try to find it. So we want to make this easy, convenient, and useful, so we're looking to develop this tool. So please look out for that, and it will incorporate a lot of the information and principles that these presentations conducted. And also, as always, please don't forget all the resources that are already available by all the partners on the phone. I think it's very much, important to remember that there's already a lot of information and resources available there. And again, to underscore, I know we say adult everywhere when we do these presentations, and it's a given, but I just want to underscore this is an adult behavioral health specific presentation and office hours, and does not address the kids components at this time. As the kids get closer to some of the transition next year, we'll be working with the state and partners to develop something similar. I also want to open the floor to any of our partners that are joining us today before we again jump into the questions and see if there's anything they would like to add, and from there we'll transition to the Q&A component. Anybody else would like to add? Okay. Wait a minute. All right. So with that, we have a couple of questions that have come in, and again, let me encourage folks to submit questions because this hour is really meant for you to be able to ask us questions as we have state folks and technical assistant partners on the phone. So our first question is, do all referrals have to go through local SPOA committees? So the answer to that, and again, I'll ask others to jump in, that not all referrals have to go to SPOA. Actually, a lot of referrals do not have to go to SPOA, but there are some, specifically like an ACT team, as an example, that would have to go through a SPOA process. So I think that's important to understand and make sure that you're aware of that. But not all referrals have to, especially when you talk about clinics and other types of services. Anybody else would like to jump in? And I just want to make sure folks have a chance to jump in here as well. Okay.
Hi, Boris. This is Nicole. I just wanted to point out that I do believe if there is a service that was included in the webinar series, that we did indicate if there was it was necessary to make a referral through SPOA. And so just a few examples that are very clearly SPOA referrals. That would be, as you stated, ACT, also AOT for care management or ACT. And some of the services that we didn't speak about, I believe, in this series, but some non-Medicaid related services would also go through SPOA. But again, if folks are looking back at the original webinars, you should see a call out to any services that are required to go through SPOA.
Excellent, thank you. And before you actually put yourself on mute, Nicole, there's an ACT question. Are the ACT teams required to complete both the brief and full eligibility assessment?
Okay. The ACT teams who are serving HARP members, all of those HARP members must have an eligibility assessment or brief assessment conducted annually. as per the ACT team's responsibility as a care coordinator in that role. And the only time a full assessment will be completed is at the time of discharge, and there is guidance issued by the Office of Mental Health to describe what that warm handoff looks like to a health home care manager and how the workflow plays out with that handoff. In essence, the ACT team is working on a discharge plan. If HCBS is a part of that discharge plan, the full assessment will be conducted. There will be referrals to a care manager and referrals to HCBS providers, and that would be coordinated between the ACT team and the health home care manager. In all other cases, on an annual basis, HARP members must be assessed through the eligibility assessment, but not the full in the case of those served on ACT teams.
Great, thank you. So here's an interesting question we got. I'll try my best to answer it, but I really would love others to jump in. And here it goes. What is the difference between care coordination versus care management? So I think a lot of times that is used interchangeably by a lot of folks, especially when there's a reference to health homes. I know in the managed care environment, a lot of times it's care management that's predominant use of that. I am not sure if anybody wants to jump in here and have any additional information in regards to that question.
This is Nicole. I guess what I would just point out is that they are used interchangeably, absolutely. From a state perspective, we refer to health home care managers as care management agencies. That would be the downstream care management providers, and so it's sort of called out in that way. Care coordination in respect to the health home program is a specific core service under health home, and so you may hear that service type was under health home referred to formally in that manner. Otherwise, I think, Boris, you were right in that some folks do use that interchangeably, and not just within our state, but across different states regarding care coordination and the different roles of a care manager.
Great. Doug, did you want to add something, or just wanted to make sure?
No, actually, Nicole said exactly what I was going to say regarding that care management as a service provision includes care coordination as one of its component services versus what you call people in what their role is. You can call a person a care manager or a care coordinator. Those are terms of art regarding what they call themselves in their positions.
Gotcha. Great. Thank you. So we have another HCBS HARP question here. Is when a Medicaid recipient has an H1 code, does that mean the person is not eligible for HCBS? And if so, why? Is there a way to have the person switch from H1 to H2 or H3? So I'll take a quick stab at it, and I'm pretty sure that Nicole and Doug and others probably will jump in. So if I recall this, and I'm doing this off the top of my head, H1 means that somebody is enrolled in a HARP. It does not necessarily mean they're not eligible for HCBS. It could mean that, but it does not mean that, because they still might need to get the assessment completed. And when the assessments are completed, and if they are eligible, they switch to H2 and H3 code. Nicole, Doug, others, any additional comment?
Well, I agree with you. I think that maybe the question is getting at, if somebody has an H1, how do you know whether or not the assessment has already been completed and perhaps the person chose not to have HCBS services or was not eligible for HCBS services? If the assessment is completed and they are eligible, I should say, they would move either to an H2 if they were Tier 1 eligible or an H3 if they were Tier 2 eligible. But there's nothing yet active to indicate whether or not the assessment was applied and the person was found not eligible for HCBS services. And I think we're working on getting a new H code. Is that correct, Nicole?
Yep, I think you have that accurate.
Okay, thank you. We have an interesting question here. So we have a question that says, in our county, the services that clients can receive through HCBS are already available without needing HCBS. I guess there's some contracted, county-specific, and other services. And so the question is, what are the advantages of, I guess, enrolling in HCBS/HARP when they are ready to receive these potential services? Any thoughts on that from folks on the phone?
But maybe a little more specification on what services they're referring to?
Right, so I think that the comment is that they have, within the county, people are getting HCBS-type services already. So I know it's not very specific, but if it's employment, but it sounds like it's all, but I'm not sure.
Yeah, well, for an example, let's say there's a state-funded service out there, a clubhouse or a psychosocial club, where somebody can go to, and perhaps part of what they can get at the psychosocial club would be some kind of rehabilitation, psychosocial rehabilitation component of the psychosocial rehabilitation service. So the question really is, I think, why go through HCBS when the person can easily just go ahead and participate in a service that has a similar service they don't have to go through perhaps some of the things that you need to in order to obtain an HCBS service. And I think that from a provider perspective and from a resource perspective, that our state dollars are very limited. There oftentimes might be more people that require service than the resource that's available, or perhaps who's providing these services under state funding, stretch themselves to serve all comers and really are having trouble financially because they're serving more people than the dollars really cover. So this is an opportunity to bring in another revenue stream. And then you could either serve more people that are not HARP eligible and potentially HCBS eligible, because we have many people that are not going to be enrolled in HARP. And you can continue to serve more people that might not even be Medicaid eligible that need those services because they're state-funded services. So I think it's the ability to expand the reach of these services to all people. And I would think that because we do have qualifications and competencies that are required of the people that are designated to provide these services, that there's a little bit more of a quality, quality control or a quality level that people must meet in order to provide the services as an HCBS provider.
Excellent. Great. Thank you.
Thank you. Hey, Boris, it's Liam. I just wanted to follow up on what Doug said. The nuances, too, and the way the services are delivered are a lot different as well, and that's what makes them distinct. So a good example is if, to use Doug's example of a clubhouse or a psychosocial club, if someone is interested in pursuing employment, the HCBS menu of employment services are done strictly in the community and in a way that may be different than what's available to the clubhouse. So while the services are comparable, they're not always entirely the same, and as Doug mentioned as well, it's an opportunity to explore goals in a different way when you have these additional services available to you.
Excellent. Thank you, guys. So I think one of the big components here, as we talked about, one, there's options, as I mentioned earlier. Two is HCBS is home and community, so it's meant to be out in community, and as both Doug and Liam just said, the current services might not, and in a lot of cases probably are not able to do that. People have to come into your office. So I think those are just some of the few benefits, and of course there's opportunities to expand and so forth. So that's great. Just moving us to the next question and clarification. So somebody just wants to know, when there is an H1 code that means an assessment can be done for eligibility by care manager. The answer is yes. That means that somebody has enrolled in a HARP, and the eligibility assessments could be started at that time. So I just wanted to make sure folks understand that as well. I know, and we have a question here, and I know prior to this we got a number of questions on it, and we're going to take this to our DOH partners and others, because and we have a question here about scoring the assessment because the system is down. There's a manual scoring process that's going on. We've been getting some questions on scoring. We have a question here about scoring. We're going to take that offline and talk to our state partners on what we want to focus here on, again, about the services and making sure people really understand what services are available, how they interact with each other, how programs work with services, and so forth. So we want to focus on that. So I want to make sure that the individual who asked the question that we're not ignoring, and we actually got a number of them as well. So we're going to handle those offline. So here's another question. We provide rehabilitation, restorative services. They are very similar services. If they're eligible for HCBS, can they receive both restorative services and rehabilitation and or psychosocial services? They're very similar to HCBS rehabilitation and psychosocial services. So again, I think it's very similar to before, but is there a way or anybody on the phone that can talk about, you know, or answer that particular question? If not, it's not a problem. It's not a problem.
I think it's something we're thinking through here, Boris.
Okay.
But it might be something we have to take back.
Got it. Okay. So let me just, we have a couple of other questions came in, so let me just get a moment here. Okay. So here's a question we have. Why are clients being told by their MCOs they cannot change their Medicaid from HARP back to non-HARP Medicaid? Most of them are being told that they cannot change their insurance MCO status for a year once they have been enrolled as a HARP. I think that's something that we probably need to, one, clarify what that question is, because there are different rules about people enrolling just as a pure managed care enrollment. I think, and there are some rules about locked-in period, but this is, I believe, is specific to somebody who's enrolled in a HARP and then, I guess, chooses to disenroll from HARP. And it sounds like the managed care companies are saying they cannot do that. We might, I don't know if there's an answer. I believe that's still something being worked on to clarify.
Yeah, I think that's something that DOH really needs to respond to. So,
gotcha.
Yeah.
Okay. So there's a question is, can clients deny HCBS services and assessment? I believe, as we talked about, it's person-centered. The answer is yes, technically, but I think if I can channel a little bit of Doug and Nicole and others that I've spent time working on this, I think it's also important to make sure, and this is part why this series was put together, to make sure that the individual really understands what they're denying, why they don't want this, make sure that they understand how these services are potentially could be helpful to them and help them especially in their recovery. And so, but the answer is at the end of the day, of course, it's not a mandatory service and assessment. They can definitely deny that. Others, I'm trying to see if I, you know, after months of spending time with certain individuals, actually learned something.
Yeah, I think you nailed it, Boris. And just, you know, to say again, I know we've been out there talking about this for a while, but one of the other similar questions I get is, where do I document that? And so just, again, to reiterate that the plan of care is the best place to document if somebody refused, including in your charts. And so different health homes might have different specific directives around that, but the key is really documentation. If you have a HARP member and they're required to be assessed and they refuse the assessment, make sure you document that. If you have a HARP member who's been assessed and they're found eligible, but they are not interested in HCBS, which is absolutely possible because maybe they're receiving a state plan service like PROS that is already meeting their needs, that's okay. You know, make a note that they were assessed and they were, you know, they preferred to pursue PROS. That's acceptable. You might have folks that are in a setting that's not HCBS compliant, and you make a note of that as well. And again, we're really having most of that live in the plan of care until we can get maybe a more data-specific way to capture that, and we're talking about ways to do that so we can more easily kind of do a checkbox sort of a thing when you meet with the individual, that you can enter some data and we can collect that and send it to the plan. So I know ask care managers that question as well. So we are working on something electronic, if you will, but for now documentation in the record is key.
Excellent. Great. Thank you. So again, we're going to encourage folks to ask us questions, especially as it relates to services. If there's any, you know, further clarification on both the OMH programs that we discussed, the OASIS programs, or how things interact with each other, you know, some of the potential challenges maybe you have come across when meeting with individuals and trying to determine what are the best options for them. You know, any of that, because we want to make sure that, again, one of the things we heard as we traveled throughout the state is that, you know, not everybody or a good portion of folks, especially on the health home side and even within the behavioral health provider community and within the managed care companies, you know, there's still, you know, there's some confusion or needs to be clarity on what are all the options out there, what are all the services and programs that are available, how do they really work together, right? How do I choose between PROS and the HCBS? Why one over the other, or how do they complement each other potentially, and so forth. So we you know, wanted to address all of that and want to see, again, if there's any questions or suggestions or thoughts in regards to those processes, because as people are meeting with individuals and having those discussions and making those decisions together with those individuals, we want to make sure that folks are, you know, have the best information in hand. Okay, so let's move on and give folks a chance to maybe ask some of those questions. But in the meantime, let's see what we got a couple of additional questions that we got in. If a health home client is enrolled in HARP and are completing the HARP assessment, would OMH still expect the health home assessment to be completed in addition to the HARP assessment? I think that's a lot. I'll turn it over to others.
Yep. So just to be clear, the expectation to assess HARP members, and I think folks know, are about the eligibility and the brief for the New York State Community Mental Health Assessment. Those are for all HARP members. The health home program has its own required documentation that the Department of Health calls for, and in many cases, health homes have looked at ways to streamline that a bit better for care managers. So, for example, a health home may have someone either do a full community mental health assessment or the in-house health home comprehensive assessment. But it is absolutely variable by health home. So you'd want to speak with your health home about that requirement. There is a work group out of the health home MCO work group whose focus is to streamline and, if possible and when possible, standardize assessments with the understanding that this is a significant challenge to care managers who have multiple assessment requirements, even in some cases are working with multiple health homes who have different assessment requirements. So there's a pretty focused effort right now on trying to streamline that documentation. But to date, the best way to go is to contact your health home for the individual you're serving to find out what their expectation is.
Excellent, great, thank you. So we have we have one more question that just came in. I think, Nicole, you might have covered this, but again, the question is just a generic question if HARP eligibility assessment needs to be done annually for HARP enrolled members or just a community mental health assessment once enrolled. I believe the answer is they done annually, as you have, I believe, indicated, so I just wanted make sure that gets repeated. Is that accurate?
Yes, it is, Boris, and I would highly encourage care managers to access the DOH website and look at the plan of care workflow, or the expedited workflow guidance document that will tell you very explicitly when you do an eligibility assessment, when you do go on to do the full assessment versus when you do not go on to do the full assessment, and then the plan of care. And so that document will tell you very clearly in which cases, based on the individual circumstance, that you would either complete the eligibility, move on to the full, and so on.
Great, thank you. So again, just want to make sure folks have an opportunity. So we're taking questions through the chat box. So if you do have any questions, please use the chat box to chat them in. At this time, with a number of folks that are on the phone, you know, that it's the best process for us and a more efficient way of addressing questions. And at this time, we don't have any additional questions. We'll give it another, you know, 30 seconds or a minute or so to see if any additional questions come in through the chat box. And if not, we will wrap it up and from there. So let's just give folks another 30 seconds or so. All right, so no additional questions came up. Again, I just wanted to say, you know, thank you, you know, for joining us for this time, and also hopefully folks did have an opportunity to listen to the pre-recorded sessions. They are still available and will be available in the future. So please direct your staff and others to those sessions, and we hope that those are helpful. This as well is recorded, I believe, and will be posted on our website as well. So again, just want to say thank you to everybody, and thank you to all of our partners for participating and pulling this together. And just want to say thank you and have a great rest of the day.